An introduction to critical care, presented by me, your host, Pat Nelligan. Welcome back. This time we're going to examine the lower half of the body. We're going to start with the arms. We're going to move on to the abdomen, the legs, the skin. Then we're going to roll a patient over on their back and have a look at their back, and then examine the monitors, devices, and everything else that's at the bedside. Examining the critically ill patient, part 2. Welcome back. In the previous tutorial, I introduced clinical examination of the critically ill patient, and I covered the upper half of the body. Importantly, all critically ill patients require a full physical examination at least once a day. It's systematic from head to toe, from front to back. You start by standing at the end of the bed and observing the patient. Initially, it's imperative that you identify life-sustaining therapies and whether the patient has an endotracheal tube in situ and feeding tubes or nasogastric tubes. And then, when you're ready to start formal examination, you start with the head and work your way around the face via the eyes, nose, lips, mouth, and the mouth on the inside and outside to include the tongue. Then you move on to the chest and follow the standard paradigm of clinical examination, which is inspection, palpation, percussion, and auscultation. In this tutorial, we're going to look at examining the arms, abdomen, legs, and skin, and evaluating the information from devices, monitors, and drains. Before I get started, I want to make a declaration. Far too many doctors are fixated on imaging to make their diagnoses for them. Frankly, you need to examine the outside of the body before you go fishing on the inside. Performing scans before examining patients thoroughly betrays a lack of competence in clinical abilities. Virtually everything that you need to know about a patient can be derived from careful history taking and clinical examination, from monitoring and simple tests. Exam before scan. Use the scans to either confirm or disconfirm your diagnosis. So let's move on to the arms. Some doctors may go first from the chest to the abdomen, but I go to the arms. It's a personal preference to ensure that the arms don't get forgotten. And again, you start with inspection. Look at both arms and compare them. Are they the same size or is one larger? Is there edema? Is there a deep venous thrombosis, particularly in the arm where a central line has been inserted into the neck or into the subclavian vein? Is the patient moving their arms? Is there an arterial line present? Check the arterial line site for infection. Also, where is the arterial line? Is it radial or brachial? If it's brachial, it's imperative that you check peripheral perfusion. On this patient, you may notice that somebody has drawn a line around an area. This suggests there was a delineated area of cellulitis on the arm. That seems to have receded. This is an arteriovenous fistula, and that tells you that this patient has long-standing end-stage kidney disease requiring dialysis, although they may have had a transplant, in which case a mass may be palpable in the pelvis. Now look at the hands. Is there any blanching, mottling, or ischemic changes, particularly if there's a radial or brachial arterial line on that side? Are the fingertips black, suggesting gangrene? Is there twitching or seizure activity? Is there clubbing of the fingers? This patient has mottling of the hand. This is usually associated with sepsis, but if unilateral, it may be due to an ischemic hand, and you should look for a cause. Finally, you need to palpate the hands. Are the hands warm or cold? And once you've felt the heat of the hands, then check capillary refill time. This is an extremely simple and effective guide to perfusion. Now let's move on to the abdomen. You need to lift up the patient's gown and in a dignified way examine the abdomen, starting with inspection. Is the abdomen distended or is it scaphoid? And what I mean by scaphoid is sunk in. And what I mean by distended is it globular. And when you see a big globular belly like this, you need to think of the 5 F's. The 5 F's refer to the things that can make the belly distend, and they are fluid, in other words, ascites, fat that doesn't need a description, feces, where the patient has a loaded bowel, and that's also usually associated with a lot of flatus, and finally, in half of the population under a certain age, fetus. Think about these 5 F's, or 4 F's if it's in males. Are there any visible scars? And if there are scars present, are they recent? Usually a recent scar will have a dressing over it or drains present. Is there a stoma? If there are drains present, look at the drain site. Is it infected? And look at the contents of the drain. Is there blood, serous, or serous sanguineous fluid, etc.? And how much is coming out? These are the things you need to look for. Sometimes you will be unable to see anything because of dressings. I make a point of returning to look at wounds when the dressings are being changed. You should also be able to identify a vacuum dressing or a vac, and these are used in the case of open abdomens, perhaps because the patient has abdominal compartment syndrome. The other thing that you might see are rectus sheath catheters. They will usually be attached to some form of infusion device, such as local anesthesia-filled bottles. And these are usually controlled by a very analog dial-a-flow system that you can see in this illustration. Then you need to move on and palpate and percuss the abdomen. When you're palpating the abdomen, you're looking for hepatomegaly, splenomegaly, for masses, and also to see if you can palpate a full bladder. It is my practice to always percuss a distended abdomen. You learn so much by doing this because it may be dull, or squishy, which means you're percussing bowel. It may be stony dull, where there's just no noise, and that's ascites. Or it may be tympanic due to gas. And if it is, that means that the patient is likely pseudo-obstructed with flatus distending the bowel, and this patient needs some aggressive pro-motility agents or anti-constipation measures, such as giving them phosphate enemas, glycerin suppositories, perhaps some oral magnesium citrate. Then you need to look at the groin. The groin is easily contaminated with feces, and there's always a possibility of an infection. If you look in the creases of the groin, you should also do this in the axillae. Look for evidence of some form of fungal infection or candida. You should also see if a urinary catheter has been placed and have a look in the catheter bag. I'll get back to that in a minute. So the first thing is there a urinary catheter in place? Is it a suprapubic or ureteric catheter? Look for pus at the meatus of the penis, and if there's a urinary bag, have a quick look at the urinary colour. If there's a femoral central line or dialysis catheter in place, you should address that, have a look at it. Again, look in the little window to see if it's inflamed. The urine colour is important. You should look at the volume and the colour of the urine. Normal urine, as you know, is a light yellow colour. Very dilute urine looks a little like water, and then with concentration it turns progressively darker. Amber coloured urine suggests that hemoglobin is present, and this is what you might see, for example, with rhabdomyolysis. In acute kidney injury or end-stage kidney disease, the urine is almost black. Moving on to the legs. Inspect the legs. Look at both legs and compare them. Are they the same size, or is one larger, suggesting edema or deep venous thrombosis? Is the patient moving both of their legs? Is one leg turned out more than the other? Look for any lines in the lower limbs, such as a femoral or dorsalis pedis arterial line, a femoral central line or dialysis catheter, or an interosseous line in the tibia. You look at the leg and you see this. This is the quadriceps. And clearly, these quadriceps are wasted. And this is a picture of a chronically critically ill patient with evidence of loss of lean body mass due to underfeeding, and that needs to be addressed immediately. Always look at the knees. Sometimes you'll have to peel back various devices and gowns and dressings to look at them. But what you're looking for is blue knee sign. This is an example. The mottled appearance is evidence of devastating dysfunction of the microcirculation, often in patients with sepsis, and this is a very bad prognostic sign. These are the lower limbs of a patient who has obstructed their aorta, and there is no flow going peripherally, and you can see the legs are extremely mottled and black. Is the patient wearing sequential compression devices? If not, why not? Is the patient wearing compression stockings? We call them TED stockings. If so, peel them back and look at the toes and at the back of the heels. We worry a lot about deep venous thrombosis in critical care. If the patient doesn't have these devices on their legs, there needs to be a good reason. Sometimes the patient has severe peripheral vascular disease. These are sequential compression devices placed on the right leg. Note the gap for the knee so that you can look at it, and the TED stockings that are underneath. On the right-hand side is the inflation machine. Another item that you might find in the leg is a splint like this that stabilizes the foot and prevents foot drop. This is usually seen in neurologically injured patients. In each of these pictures, the patient gave me permission to photograph them. Look at the dorsum and the toes. Assess the color and the calor. Assess the pedal hygiene. Does the patient have long nails, corns, and calluses, suggesting that they don't look after themselves? Are the toes necrotic or ischemic? And this is one of the most devastating things that we see in critical care, a black foot associated with purpura fulminans from severe sepsis, often group A streptococcus. Palpate the legs. Move the legs passively and look for resistance. Look at the muscle tone. Is it normal? Is it hypertonic? Is it flaccid? Is there cogwheel rigidity? Check a Babinski reflex. Check other reflexes if necessary, and palpate the dorsalis pedis and posterior tibial pulses. If you can't palpate them, you don't feel anything, it's worthwhile doing a Doppler assessment of them. Now look at the ankle and the heel, and press your finger in behind the back of the medial malleolus and see if there is pitting edema of the ankles. Always look at the back of the heels for evidence of the development of pressure sores. This usually manifests as an initial discoloration of the skin that eventually turns black. The skin then denudes to expose the tissues below. Now let's look at the skin in general. The skin is the forgotten organ system of the body. Many doctors are uncomfortable evaluating the skin because they feel they lack knowledge of dermatology. But in fact, skin disorders in the ICU are relatively common and they're relatively simple. First thing when you're looking at the patient is to see is there extensive bruising that's consistent with perhaps trauma or coagulopathy. If there's a rash, is it widespread or localized? We're worried about widespread rashes. One widespread rash that does not extend above the neck is scabies, and that can be diagnosed by looking for burrows between the fingers and the webs between the fingers. When you're evaluating a rash, you need to ask, is it macular, which is flat? And if it's flat, does it blanch? Is it papular, which means it has a raised element to it? Often rashes are maculopapular. Or is it vesicular, where there's little bubbles on it? Obviously, very large bullous eruptions require a dermatologist to look at. It's really important if you see a rash to see if it blanches, because a macular rash that doesn't blanch is a purpuric rash. Purpuric rashes are caused by extensive microvascular bleeding. This is meningococcemia until otherwise proven if sepsis is suspected. Not only is this just about the worst sepsis diagnosis a patient could have, but it's not the only really nasty diagnosis that causes purpura. Thrombotic thrombocytopenia purpura is a devastating disease that may kill a patient unless they get plasma exchange. You also see purpuric rashes with vasculitis, and ITP. Occasionally you'll see a localized purpuric rash on an arm or a leg where a tourniquet has been on for a long time or a tight blood pressure cuff has been on, but it is not widespread. And if it's not widespread, it's not the same as what I'm talking about with TTP and meningococcemia. Another really common rash is a diffuse maculopapular rash. This is a flat pink rash that erupts. It's initially flat, then it's raised, and then it becomes confluent and then progressively covers the body. This is a drug eruption until otherwise proven. In that situation, you need to look very carefully what drugs the patient is on, stop any antibiotics they're on, and if you've had a patient on, for example, Septrin or some sulfonamide, be aware that furosemide is a sulfonamide. You might want to stop that as well, but you need to be really careful about what drugs the patient is on. Now, once you've evaluated the skin on the front, then you need to have a look at the patient's back. The patient needs to be rolled onto their side, and you need to have a good look at the back. And there are several things that you need to look for. I usually have a look at the back when the nurses are turning the patient. It is worthwhile to mention here that the patient may have pain catheters implanted in their back. These are usually lumbar epidural catheters, thoracic epidural catheters, or paravertebral catheters. Often these catheters are covered by a dressing. It's worthwhile to lift the dressing and look at the site once a day. The catheter may leak, or there may be some blood around it, or the site may be inflamed. The epidural or paravertebral catheter will be connected to a computerized pump. The other item that you will want to look out for is a bowel management system. Believe it or not, this is one of the great advances in critical care over the past 25 years, and you need to look at the contents, particularly the color of the contents. Where there is body weight, there is compression, and that leads to the risk of pressure sores. So you need to look carefully at the sacral area and the buttocks if there's any breakdown of the skin, and also for any evidence of deep-seated infection and the presence, as I've mentioned, of a rectal tube. I just want to show you the most important pressure points in the supine position. These include the occiput, the scapulae, the olecranon, this is where the ulnar nerve is compressed by the elbow, the sacrum, the ischium, and the calcaneus. And these are the areas where you'll see pressure effects. The back of the head, around the shoulders, around the buttocks, and on the heels. And once you've evaluated all of that, you've finished your clinical examination. It's now time to start looking at the monitors. This is a standard ICU monitor. I will usually have eyeballed the monitor as soon as I got to the bedside to make sure that the patient isn't acutely distressed and does not need immediate intervention. But let's work our way through the monitor. In terms of standard monitoring, every patient gets an electrocardiograph. And when we look at the ECG, we're looking at the rate. Is the patient requiring pacing to achieve this rate? In a cardiothoracic ICU, patients will frequently be paced post-op, and you do need to know what the underlying rhythm is when you turn off the pacemaker. Also, is the patient in sinus rhythm, or are they in atrial fibrillation, atrial flutter, or do they have a lot of premature atrial or ventricular contractions? Is the QRS complex normal, or do they have a bundle branch block? Is there some ST segment elevation suggestive of a recent myocardial infarct or pericarditis? Arterial blood pressure monitoring is essential in the ICU. It's either achieved through a non-invasive blood pressure cuff or an arterial line. Generally, if a patient is in intensive care, they will have an arterial catheter placed, and we measure systolic, diastolic, and mean pressure. The mean pressure is the big one. That's where most doctors set their goals for perfusion. And you must know if the blood pressure is mean pressure of 65, has that been achieved by support by vasopressors, inotropes, or intra-aortic balloon counterpulsation. We also look at pulse pressure variability or stroke volume variability to determine whether the patient is fluid responsive or not. And we look for the correlation between the arterial line and the blood pressure cuff. Pulse oximetry is also used to determine the patient's oxyhemoglobin saturation on the pulse oximeter. Generally over 90% is where we want to be, and we will also perform capnography to look at end-tidal CO2 and the capnograph trace. And these are what we would consider absolute standard monitors in any patient in the ICU. Obviously, we only use capnography in someone who is ventilated. There are some special monitors, such as central pressures, using a central line to measure central venous pressure, or pulmonary artery pressure, or pulmonary capillary wedge pressure. There's a variety of different cardiac output monitoring devices out there, but generally they will give you a cardiac output and a stroke volume, plus or minus stroke volume variability. And with Swan-Ganz catheters, we'll be looking for mixed venous oxygen saturation and central temperature monitoring. There are some neurological monitors that are used. For example, bispectral index is used to monitor sedation in the ICU. Some patients will have continuous EEG, for example, if they have status epilepticus or subarachnoid hemorrhage. And of course, if you're in a neurosciences ICU, the patient may well have intracranial pressure monitors of various shapes and forms. This is an external cardiac output monitor known as MoseCare. And there are various devices available on the market that use pulse contour analysis of the arterial line to calculate stroke volume, cardiac output, and pulse pressure variability. Now, although I've kept this very short, there's quite an immense amount of information to be derived from these monitors. And then once you've looked at the monitors, you need to start looking at the machines. Mechanical life support is primarily provided by the mechanical ventilator through an endotracheal tube or tracheostomy. I briefly mentioned non-invasive ventilation earlier on. We'll put that aside for now. The purpose of the ventilator is to oxygenate and ventilate the patient and protect the patient's airway through the endotracheal tube. And once the patient's on a ventilator, you need to look at the ventilator and establish several pieces of vital information. Obviously, whether it's invasive or non-invasive, you'll know this because the patient will have an ET tube or tracheostomy for invasive ventilation. You need to know if the patient is actually breathing themselves. That can take two forms. They can have assisted breaths or spontaneous breaths. There isn't a huge amount of difference between the two. On these Puritan Bennett ventilators, as you see on the picture, there's an A for assisted breath in certain modes of ventilation and an S for spontaneous breaths in other modes of ventilation. And so what you need to know is what mode they're getting. Is it volume control or pressure control? Is it assist control, SIMV, synchronized intermittent mandatory ventilation, bi-level, or pressure support ventilation? In the case of pressure support, that will be a spontaneous mode. There are other modes such as tube compensation and proportional assist, but they're not commonly used in the ICU. You need to know how much oxygen the patient is getting, how much PEEP they're getting, and what their PaO2 FiO2 ratio is. If there is more information to be collected, what I would suggest is you look for the plateau pressure, the lung compliance, usually dynamic, but you can measure static compliance, and airway resistance, again static or dynamic. Then you need to look a bit further afield. Is the patient receiving kidney replacement therapy? If so, is it continuous on the left or intermittent on the right? If continuous, what strategy is being used? This is usually CVV-HDF, continuous veno-veno hemodiafiltration, but sometimes we use slow continuous ultrafiltration or SCUF. Are we removing fluid? How is the system anticoagulated? The standard of care is to use citrate, but the patient may be receiving a traditional strategy using heparin or other anticoagulants. Are there any other unusual devices in use? This is a patient post-cardiac surgery, and the device is an intra-aortic balloon pump. The device on the right is for delivering inhaled nitric oxide. Now, this is usually used for profound hypoxemia or resistant pulmonary hypertension. This patient is receiving plasma exchange for Guillain-Barré syndrome, and this is a whole plasma exchange system. This will not be continuously located in the ICU, but you might wander in and see this device attached to a patient. It looks a bit like a dialysis machine, but the giveaway is all that yellow fluid that's hanging up. That's all plasma that's being taken off the patient and going back into the patient. And this, of course, is a defibrillator attached to an ICU patient, often an ominous sign. Look at the drains, pumps, and infusions. This is obviously an IV bag of fluid, and if you see IV fluid up, you want to see what the patient is on. In this case, the patient is getting sodium lactate solution. The different intravenous things that we give to our patients include fluid and electrolytes, vasopressors and inotropes, sedatives like propofol, dexmedetomidine, opioids, benzodiazepines, antibiotics, food, TPN and supplements, antimicrobials, insulin and corticosteroids, and finally heparin and other anticoagulants. Typically, you will see a battery of infusion pumps. These ones are syringe drivers that are popular in Europe beside the bed, and they should be clearly labelled with the particular drug and the rate of infusion. In the case of vasopressors such as noradrenaline, norepinephrine, and vasopressin, you will want to know what dose the patient is receiving and whether it is increasing or decreasing. ICU patients are frequently sedated, for example, here with propofol, and you will want to know the dose of sedation that the patient is receiving and the goals for sedation using, for example, the Richmond Agitation Sedation Score. Likewise, the patient who's been in the ICU for a few days should be receiving some form of nutrition, usually enteral feed, and you'll want to know the amount being delivered in mils and the calorie content of the feed. This one is 1 calorie per mil, so the goal for this patient should be 1 mil per kilo per hour or thereabouts. They may also be receiving enteral water. This is a bag of total parenteral nutrition. The food is light sensitive, so it is covered with a plastic bag. If a patient is on TPN, there is a background reason why they're on this, and you'll want to know why the patient is not getting enteral feed, which is generally preferred. Also, you need to have an idea of what's in the bag. In this case, we have a green bag, indicative of a la carte TPN. This almost certainly reflects intense scrutiny by the unit dietitian. The red TPN bag that you will see in our unit is usually an off-the-shelf product. Nothing wrong with that, but you need to pay a little bit more attention to the contents to ensure that the patient is getting at least 1 gram per kilo of protein per day. If the patient has a chest drain, you need to check how much it is draining, whether it is oscillating, meaning that it's not blocked and that it's moving with air going in and out of the lungs, and whether it's bubbling on expiration, suggesting an air leak. When you have completed your physical examination, ensure that you leave the bedside exactly as you found it. In particular, make sure that the patient's gown is covering them and that their sheets are in place. If you've made a mess with syringes or papers, please clean up after yourself. Put your gloves and apron in the bin. Do not wear an apron or gloves away from the bedside. If you have made any changes to the ventilator or the infusions, inform the nurse or respiratory therapist immediately. If you have made any new observations or new diagnosis, inform the nurse. Then record your findings. In this tutorial, we talked about the head-to-toe, front-to-back system for clinical examination of the critically ill patient. This involves inspection, palpation, percussion, and auscultation. You start with the head, then you move on to the neck, then the chest, then the arms, abdomen, legs, and skin. Following examination, you look at the monitors, and then the machines, and then the pumps and infusions, and any drains that you haven't already checked. Next time, I will discuss how you obtain and assess laboratory and radiological data, how to integrate your observations with the nurse's observations, and how to put the story together. I'll see you then, and I guarantee you'll learn something. So that's physical examination. It's now time to leave the bedside and go look at the information system and the chart and all the other information that's been accrued on the patient, and we're going to put it all together. If you're enjoying these tutorials, please subscribe on YouTube, leave me some comments and some likes, and follow me at ccmtutorials.org.